Hello, everyone, and welcome to today's symposium on pulmonary embolism. It gives me immense pleasure to introduce my dear friend from Bangalore, Dr. Murli Mohan. Murli is a senior respiratory consultant at the Narayan Rudnalaya Hospital. Having done his FRCP and MRCP in the UK, he's authored more than 50 papers, even has been on a WHO advisory panel for the smoking cessation. Obstructive airway diseases, interstitial lung diseases, and pulmonary hypertension are his core interests, and whenever I speak of pulmonary hypertension and pulmonary embolism, Murli's eye just light up like this. There is going to be a twinkle in the eye which you are going to see in today's symposium, and I'm sure it's going to be an extremely enlightening session, especially with respect to the current pandemic, where we have these kind of embolic acute and chronic embolic complications in the COVID-19 disease as well. So over to you, Murli, and looking forward for an exciting session.
Good evening. I'm really happy to be here, invited by the CCI to talk on acute pulmonary embolism. And I'm excited after that very warm and personal introduction by my good friend, Dr. Kumar Doshi. Special thanks to Dr. Krishna and Dr. Vijay Chetty, who's overall overseeing these masterclasses. And of course, to the office bearers of CCI for giving me this opportunity. I'm talking today on a very important topic. As Dr. Kumar Doshi said, this is one of my passions and has become especially important in this time of COVID. But what I will be talking on is not just going to focus on COVID. It's going to talk mostly about acute pulmonary embolism, as it has always been a problem to us. We started off knowing more about this condition with Rudolf Virchow, who gave us his so-called triad: changes in the circulation, changes in the vessel wall, and changes in the blood. And these increase the risk of having a thrombosis. And when a venous thrombosis breaks off and a clot enters the pulmonary circulation, we call that an acute pulmonary embolism. And you're seeing frightening examples both in the veins and in the pulmonary arteries on the right side of this slide. I start off with a patient of mine, a young 27-year-old male, who came to us with a history very typical of pneumonia. So he had hemoptysis, which was moderate in severity, very severe left lateral chest pain, and he'd had tenderness in the same area. He also gave us a history of fever and cough with expectoration. So I think quite rightly we thought of acute pneumonia as the first possibility. However, there were a few points. His pain was a little severe, and his symptoms had started all of a sudden. 1 second nothing, next second he was having severe pain. So we were wondering what was happening. And then he told us that he'd been traveling for some time over the previous couple of days, long journeys in his car. So then we went on to do a CT scan first, which showed us signs typical of an infection, and that's what it was reported as. As you can see in the remarks, features concern for infective etiology by our radiologist, an extremely good radiologist, very, very good, especially at pulmonary vascular diseases. But as we were not happy, we went ahead the next day and did a CT spiral angiography, a CTPA as we call it. And this showed us very definite evidence of central filling defects on both the right and left lower lobe. In fact, the impression on the right side, you can see just a clot load of 8%, but acute pulmonary embolism with a pulmonary infarct involving the left lower lobe with a very small pleural effusion. On the background, there were also some features suggestive of mild pulmonary hypertension. As you can see in this part of it, the MPA to aorta ratio, the ratio of the diameter of the main pulmonary artery to the aorta, usually measured at the level of the carina, was greater than 1. Normally, it should be less than 1. So this tells us that this patient has probably had pulmonary hypertension. And more worryingly, that this might have been not the first episode, but a chronic pulmonary hypertension. because with an 8% clot load, you do not expect to develop pulmonary hypertension. So the main thing that we must learn from this whole episode and several other similar episodes in the past is that the key to the diagnosis of an acute pulmonary embolism is high clinical suspicion. That's the most important. Keep your eyes and ears open. Anything out of the ordinary, suspect the pulmonary embolism. So what I plan on taking you through today is how common is acute PE? When does one suspect an acute PE? How does one confirm the diagnosis? Once confirmed, how do you risk stratify the acute PE? Because based on risk stratification, you have to manage an acute PE, and the whole management plan changes with each risk stratum. So how common is this condition? Well, a clinically relevant PE is much less common than a pathological PE as discovered by autopsies, which overestimate incidence and mortality rates due to PE. And in fact, if you look at acute PE presentation in the ER and you do a CTPA or other investigations for this, an acute PE is confirmed at only 6 to 9% of those who are investigated. Among inpatients, however, the incidence is much higher, 25 to 30%, telling you that among inpatients, many patients also develop acute PE in hospital. And overall, PEs seem to be getting commoner. If you look at the left-hand graph, the incidence rate in every single country in the developed world is rising and continues to rise at different rates. Fortunately, the case fatality rate everywhere is coming down across multiple studies. What does this mean? It probably means that A, we are getting better at identifying and managing PE, but also that we are picking up smaller and smaller PEs that don't have high case fatality rates. And this reflects our improved diagnostic skills, both clinically as well as imaging-wise. Having found out that PEs are common, how dangerous is it to have a PE? Well, about less than 5% go on to have an ultimate outcome of mortality. And among patients who are stable hemodynamically and who have no significant 2D echo changes suggestive of right ventricular dysfunction, this happens in only about 2 to 3%. However, but we must remember that the number of PEs are very, very common if you take the overall population. And pulmonary embolism, acute pulmonary embolism, is the third most common cardiovascular illness in the United States. And you can see here, compared to breast cancer, AIDS, and car accidents, pulmonary emboli far outnumber those as causes of death annually in the United States. However, we must remember that car accidents and breast cancer may also lead to PE, which may be the cause of death. So it's very difficult as to find out which was estimated as the actual cause of death. Underlying malignancy, underlying immobilization due to a car accident, or did they attribute it to the PE? But let's not underestimate the importance of pulmonary embolism. 40 to 50% of patients with a DVT develop a PE, which is often silent. And a PE may present 3 days to a week after a DVT. And unfortunately, about 10% die within an hour of the onset of respiratory symptoms, not giving you very much time to do much. 5 to 10% have shock or persistent hypotension. 50% of those with right ventricular dysfunction have shock and persistent hypotension. And if untreated, patients die. And most fatalities occur in those who are not treated. However, treated, perfusion defects completely resolve in 75% of patients who survive. So if you can see them through this acute period, identify and treat them appropriately, most patients will get better, completely better. What are those clinical features which will increase your suspicion of an acute pulmonary embolism? So there are some typical symptoms. Dyspnea, especially if we have no explanation for the dyspnea. Chest pain, especially if the pain is pleuritic. Hemoptysis, as in our patient who had all these three features. But a very important, often missed thing is syncope. Syncopal episodes, unexplained, are often a signal that the patient had an acute PE, especially in conjunction with the other symptoms. Signs that are important but hardly specific are tachypnea, tachycardia. Useful is if you look for signs of DVT, either new or old. And of course, hypoxia, which is disproportionate to what you see on an X-ray or a CT scan. But we must take this with a warning. These signs and symptoms occur in many diseases, typically in pneumonia, for example. And this classic triad of dyspnea, pleuritic pain, and hemoptysis occurs in less than a fifth of confirmed pulmonary emboli. So don't rely on these. We often do these initial investigations, ECG, chest X-ray, and ABGs. They should be done, of course, but they're neither specific nor sensitive enough to confirm or exclude a diagnosis of pulmonary embolism. And they may provide an alternative diagnosis when you do it. For example, you may pick up an acute MI, which may present with fairly similar symptoms. Very importantly also, they influence your assessment of the clinical probability of disease. So if you have a clinical suspicion, what is the next step? The first step is to do what is called the PERC, or the pulmonary embolism rule out criteria, so I call it PERCA. Start off by looking at the PERC rule out criteria. Basically what this does is it looks at what are the features which are telling you there's a high risk of pulmonary embolism, and taking the opposite, what are the features which are not for high risk. So a younger person is at lower risk, a person who's not tachycardic is at lower risk, a person who maintains a saturation is not very likely to have it. He has no features of DVT such as unilateral leg swelling. There's been no hemoptysis, no predisposing factors such as recent trauma or surgery, no history of previous DVT or pulmonary embolism, and no use of oral hormones which increase the risk of pulmonary embolism. So if the person has none of these, they're probably at very low risk. So you should have a low clinical suspicion. This is only if the person fits all 8 criteria. And if you have all these not existing, then perhaps no further testing is required. But a very, very important caveat, PERC is usually not applied in pregnancy. Some papers have come out recently questioning this, that you can actually use these even in pregnancy. So we've used various criteria, and one of these criteria is the so-called Wells criteria or modified Wells criteria. But I'll go on to the simpler criteria that we use. Incidentally, the Wells and the modified Wells are available on online calculators. But you can also get the simplified Geneva score, and I like this because it's simple. It uses practically the same features we found in the PERC rule-out criteria, and it talks about what are the risks which are high and which summed up together will tell you what is the pre-test probability of having a pulmonary embolism. So age greater than 65, having had a previous DVT or PE, a surgery or fracture within a month prior to this episode, an active ongoing malignancy, unilateral lower limb pain and or swelling, hemoptysis, pain on palpation of the deep veins in one leg, a heart rate which is between 75 and 94 is 1, but if it's greater than 94, you add 1 more. And that's easy to remember. So you just have to remember the risk factors. And if a person scores 2 or less, the person has a low probability for PE. A score of less than 2 plus a negative D dimer, which is the next step for you, is a likelihood of PE of 3% or less. On the other hand, if the score is 2 or more, then you probably have a high chance of having PE. So a score of less than 2, low probability. Less than 2 plus negative D dimer, higher probability. A probability of less than 3%. More than 2 or a D dimer which is positive, higher probability. We all know what D dimer is. I'm not going to waste much time on this. Just to tell you that it has a very high negative predictive value and a low positive predictive value because it can be influenced by many things. Secondly, ask yourself how the D dimer was done. An ELISA-derived assay, which you can ask your lab for how they're doing it, has the highest sensitivity, whereas you do a latex or a whole blood agglutination assay, it has a lower sensitivity. And I'm not going to again go into this, but you have a lot of condition which gives you false positives and false negatives. So if your initial screening score, that is the Wells, modified Wells, Geneva or simplified Geneva, indicate a high probability of PE, you don't even need to waste your time waiting for a D dimer. Proceed straight to CT scan. A negative D dimer can miss up to 15% of patients in this group. However, if you have an intermediate or a low possibility of PE on the screening score, then do a D dimer next. So negative D dimer, no PE, look for an alternative diagnosis. a positive D-dimer, please go on to do an imaging. So thus far, we have an investigation algorithm that goes as such. You start with a clinical suspicion of pulmonary embolism. You do a risk assessment using a simplified Geneva score or one of the alternatives. You have three possibilities. You have a high pretest probability, you have a low pretest probability, and you have something which is intermediate at a score of 2. If you have a high pretest probability, proceed straight for referral for treatment if the person is hemodynamically unstable, which I'll come back to, and or imaging. If you have an intermediate or a low pretest probability, proceed to do a D-dimer. If the D-dimer is negative, you don't need to do anything more. If the D-dimer is positive, despite the low pretest probability or an intermediate pretest probability, proceed to imaging. I hope things are clear up to this point. So we spoke about imaging. Which imaging procedure do you use? So if you have the choice of doing a VQ scan, you do a VQ scan if the person's chest X-ray was normal. The person has no known structural lung disease. In a younger person, if a person has renal dysfunction and you don't want to use contrast, and if you don't have an alternate diagnosis as a strong possibility requiring a CT rule out, we use something called a triple rule out, which looks for MI, which looks for dissecting aneurysm, and which looks for acute PE, all in a single CT angiogram, which looks at a coronary angiogram, looks at an aortogram, and looks at a pulmonary angiogram, all in the same CT scan, doing it at different times. And of course, the most important is a VQ scan should be available. However, if you need to do a triple rule out, or you have an older person who's therefore at higher risk, if a person has an already abnormal looking chest X-ray, which means he either has a PE or he has a known structural lung disease, so a CTPA will be useful in picking up the structural lung disease. And of course, if the VQ scan is not available, you proceed to do a CT pulmonary angiogram. A VQ scan is useful if you have a normal report to it because it's got a very good negative predictive value. It's also very useful if you have a high probability scan. Unfortunately, it's diagnostic in only 30 to 50% of patients, and you may need to go on to do yet another scan after that. So I'm not going to go into this. You could have, in the presence of high pretest probability, you may have PE which is possible, or probable, which is a high probability PE. If you have a high probability PE, you can start considering treatment straight away. If you have a low or intermediate probability scan with an intermediate probability pretest probability, then you need to do further testing. However, if both the pretest probability and the interpretation on this VQ scan suggests low probability, you suggest that you look for an alternate diagnosis. So these are some typical pictures of an acute pulmonary embolism. This is a saddle pulmonary embolism. This is an acute pulmonary embolism in the right main pulmonary artery. However, a chronic PE is different, and I'll come back to this. And some patients tend to have acute on chronic PEs, as is seen in this patient. And I'll come back to this question right at the end. I already spoke about if your mean pulmonary artery measured at approximately the carina is wider than the aorta, the diameter is greater than that of the aorta, you have a very high likelihood of pulmonary hypertension. And if you have infarcts and you have bilateral pleural effusions, not showing up so well, I'm afraid, on this, but you can just about catch sight of it there and there, then you probably are dealing with a high probability of having pulmonary embolism in the right circumstances. In pregnancy, you skip the OPERC, you do a lower limb venous Doppler ultrasound as the initial radiological test of choice, because pregnant women are most likely to have emboli emerging from the lower limbs. If it is positive, you start treatment. If it's negative, you consider doing an alternative imaging, such as a VQ scan, because a VQ scan reduces radiation exposure to the breast tissue, and this radiation exposure by a CT pulmonary angiogram to breast tissue increases the subsequent risk of breast cancer in the future in a pregnant woman especially, or in a lactating woman. So we prefer to do a VQ scan, which gives you something like a 3 millisieverts, whereas a CTPA gives you anything between 10 and 20 millisieverts, increasing the risk manyfold. So if you've confirmed your pulmonary embolism by one of these imaging strategies, then you proceed to a risk stratification of these patients. The treatment of a PE in the acute phase depends on the assessment of the patient's early risk of death. So if the person has a high risk of death, you are more aggressive. If you have a low risk of death, you can be a little more conservative. Okay, so risk stratification of the PE, not what is the risk of having a PE, but this is a confirmed PE. So what is the risk of having a problem if you have this PE is what we are doing at this stage. This is risk stratification. Central to this risk stratification is several features. Does the patient have a hemodynamic compromise, which is the single most important thing and determines early action. If the person is hemodynamically stable at that point, you look for the presence and severity of RV dysfunction. And then you go on to look at markers which will tell you that the patient has RV or LV myocardial ischemia as the third component. So hemodynamic compromise, is there RV dysfunction? Are there biomarkers for myocardial ischemia? Okay. And why is this important? Because the greater the severity of the pulmonary embolism, and this goes partly on embolism size, but much more on cardiopulmonary status, is as the dysfunction increases, going into shock and then later cardiac arrest and sudden cardiac death, the mortality rate rises, fairly steadily. And after RV dysfunction is reached, it rises very sharply, as shown in this graph. So how is high risk classified? The North Americans use the term massive PE. The Europeans use a different term. They speak about high risk PE. And this is, as I've already said, recognized by the presence of a clinically overt RV failure, which has resulted in hemodynamic compromise. The most classic features being hypotension or syncopal episode, which means brain perfusion came down abruptly. It could be pulseless electrical activity, which will present as a cardiac arrest, or it could present with refractory hypoxemia, despite everything you're doing to improve the oxygen level. So people with these, hypotension or syncope, or a cardiac arrest, or refractory hypoxemia, all could be classified as having high-risk PE or massive PE in the North American classification. This is not very common. As I mentioned right in the beginning, it occurs in less than 5% of patients presenting with an acute PE, but is a very important medical emergency associated with at least a 15% risk of in-hospital death, particularly during the first hour or so after admission. The next is what is called an intermediate risk PE by the Europeans or a submassive PE by the Americans. This is a patient who's initially normotensive but has a proven acute PE, but he has an elevated risk of death in the major complications the next few hours to days. And therefore, these people should be put in a slightly higher risk group and possibly receive very specific advanced therapy. What actually happens when a person has an acute PE is they go to a spiral of hemodynamic compromise. If you have a saddle embolus, the person may lose consciousness immediately and go into an arrest. But a person who doesn't have this large an embolus blocking off circulation to both lungs will probably end up with an increased right ventricular afterload. This is followed by dilatation of the right ventricle, usually the tricuspid regurgitation. The right ventricle, because of its overload, develops increased wall tension. There's a series of neurohormonal and myocardial inflammatory changes. And I'll remind you, especially in the setting of COVID, that the immune system, the neurohormonal system, and the myocardium, the circulatory system, are all intimately connected with each other. This leads to increased right ventricular oxygen demand. There's intrapulmonary AV shunting, which obviously worsens hypoxia. There's right ventricular ischemia as a consequence when the ischemia of the whole body occurs, and thus hypoxic injury to the right ventricle. So the right ventricle, which is already overloaded, receiving less oxygen, contracts poorly. The right ventricular output drops. So the left ventricular preload drops. At the same time, what is happening because of the right ventricular dilatation, the interventricular septum is getting shifted to the left. So there's also decreased filling of the left ventricle because of increased ventricular resistance. The cardiac output drops when the LV preload drops. Because the cardiac output drops, the systemic blood pressure falls. When the systemic blood pressure falls, remember the coronary arteries take origin from the root of the aorta. So the aortic root pressure falls, the coronaries are not being perfused properly. The heart, including the right ventricle and the left ventricle, are not being perfused properly. So the right ventricle suffers further oxygen damage, And this keeps going in an unending spiral, right ventricle and left ventricle both getting damaged by this. So what we use is to classify the severity of pulmonary embolism. We use something called the Pulmonary Embolism Severity Index, which includes both the age, which is obviously a risk factor for poorer outcomes, the comorbid conditions, and the clinical findings. And we use these days something called a simplified PESI, which is far easier to use than the old PESI, and shown to have practically the same yield as the old PESI. So every one of these features carries 1 point. So if you have an age which is greater than 80, a history of cancer, COPD, which is of interest to pulmonologists like us, tachycardia, especially with a heart rate greater than 110, hypotension, a systolic BP of less than 100, or desaturation to below 90%, each of these carries 1 point. And if you have any one of these, this will tell you that the person has a high risk. So what we classify as low risk and high risk is based on mortality at 30 days. And if you have a mortality predicted by these papers at less than 1%, this is a low risk. If it is greater than 10%, is a high risk. So just score anything greater than 1 on this list of 6 as being of high risk and treat them as high, intermediate, high risk. We also use biomarkers, and ideally we need to combine biomarkers with clinical scores and or imaging for a comprehensive risk stratification. And what are the biomarkers that are used? Apart from heart type fatty acid binding protein, which we don't have, I don't know how widely available it is in the country, but something that all of us have access to are the cardiac troponins, TROP-I and TROP-T, and the natriuretic peptides, BNP and NT-proBNP. Cardiac troponins are highly sensitive and specific markers of myocardial cell injury. And while we use them often for myocardial infarction, remember that the RV and the LV also get damaged in the pulmonary embolism, so they arise in pulmonary embolism. And I've already taken you through the pathophysiology of what happens. So they are very useful in risk stratification, and an increased troponin is associated with a mortality risk of almost 6 times that of a person with normal troponins. And this is consistent even in normotensive patients. So though your patient appears hemodynamically stable, if the person has an elevated troponin, this is a person at high risk. The BNP and NT-proBNP are also useful because they are released in response to myocyte stretch. So when the RV gets stretched, you get a release of the natriuretic peptides. Unfortunately, we don't know the cutoffs as to what really gives you the cut for a high risk from a low risk, but we probably think an NT-proBNP of greater than 1000 or a BNP of greater than 500 can fairly specifically identify patients who are at high risk. However, NPs, natriuretic peptides, can occur in many conditions that rise, and we know, however, that it has a good negative predictive value. If you have a low natriuretic peptide, there's a low risk of complications and mortality. Raised ones don't have as good a predictive value. I'm not going to go into the fatty acid binding protein, which is the heart type, because we don't have it in most places, but it seems to also have a very, very good negative predictive value for an adverse prognosis. So we go on to echo, which is available in most emergency rooms and most ICUs these days. So it's very important to do an echo as fast as possible and have somebody who knows what he's looking for. And I'll come back to this. And why is this important? Because if you have no RV hypokinesis at onset, then you have a much better prognosis than a person who has RV dysfunction or hypokinesis of a part or whole of the RV at the onset. Much higher mortality rates. You can see the 30-day mortality is almost 8 to 10% higher. And this has been shown across multiple studies, as this forest plot shows you. Very good predictive value for mortality, quite a high mortality level if a person has RV dysfunction. What do you actually look for? You look for an enlarged right ventricle in the parasternal long axis view. You look for a dilated RV with what is called the McConnell sign, where the apex of the ventricle is spared, but there is regional wall motion abnormality in a part adjacent to the apex in the right ventricle. The interventricular septum gets flattened out because of the high right ventricular pressure, and you have a distended inferior vena cava with diminished inspiratory collapsibility, and these generally most people can pick up. The next set are a little more complicated. I'm not going to go into the first because it requires an experienced echocardiographer. But if you can calculate the tricuspid valve gradient and pick up on what is the pulmonary pressure, it will be high in these patients, though not very high. You can also sometimes see the clot actually, and you can look at what is called the TAPSE, which is useful in all kinds of pulmonary hypertension, the tricuspid annular plane systolic exertion, which tells you basically how much the tricuspid annular plane is moving. Obviously, if there is right ventricular dysfunction, it moves much less than in a person who's got good right ventricular contractility, where it will move much more. You can also look at the CT pulmonary angiogram for evidence of RV dysfunction, where the RV is dilated. As if you look at the RV to LV short axis, if it is greater than 1, you can also look at the RV to LV short axis greater than 1.5 will tell you it is severe. And as already mentioned, if the interventricular septum is bowed to the left, very good CT evidence of RV dysfunction. So to summarize what I've said in this part so far, you first assess the hemodynamic stability using simple things like the blood pressure, pulse, and so on. You go on next to calculate the simplified PESI score, the Pulmonary Embolism Severity Index score. Anything 1 or more will tell you that it is very high risk. You go on to do lab tests, which are the biomarkers, and imaging, which includes both echocardiography and CT pulmonary angiogram. And based on these, you take action. What is the action you take? First of all, as I said, step 1, you look at the hemodynamic stability. If the person is in shock or hypotension, straight away puts the person into a high risk. And you need to take the approach that I will come to later. If the person is hemodynamically stable, then you classify this person as a non-high risk or non-massive PE, and then you go on to the next step. You check either the simplified or the regular PESI. If the person is in PESI class 3 or 4, or class less than 2, that is a simplified score of less than of 0, or a simplified score of greater than 1, 1 or greater than 1. If it's 1 or greater than 1, he goes into an intermediate risk. If the person is 0, then it's a low risk. So you calculate the S-PESI or the PESI. Step 3, you go on to use the lab tests and the imaging, and ideally I would suggest you do both. You do a lab testing or imaging procedure. If a person is at low risk, you've done these lab parameters, you've done the imaging, and if all these suggest that there is no increased risk, the person is at low risk, you can probably send this person home with treatment. Remember, this person has already been tested to be positive, but his risk is low, so you can consider treating him as an outpatient with all the appropriate warnings. However, if the person is at intermediate risk according to the PESI, you look for evidence of RV dysfunction either on imaging, echo or CT, and you look for the biomarkers. If both are positive, this person is now classified as intermediate high risk. If the person has one of these features as being positive, then the person is considered as intermediate low risk. So low risk, but intermediate low risk, not low risk. Okay. So I'll go back to this because this step is important. Hemodynamic instability, straight away think of starting treatment aggressively, and I'll come to this later. If it is not high risk, he is either intermediate or low risk. You determine this intermediate or low risk by doing the simplified PESI score, which you remember looked at what are those factors which tell you this person is at high risk having a poor outcome. 1 in 6, anyone positive is at intermediate risk. None of these positive, he's at low risk. If the person is at intermediate risk and has either biomarkers or RV dysfunction on imaging, then the person is intermediate low risk. If the person has RV dysfunction and biomarkers being positive, is intermediate high risk. If all are negative, then he's at low risk. So you take the appropriate action. And to summarize it in one slide, if a person is at high risk, you immediately proceed to rescue reperfusion therapy. This may be thrombolysis, it may be surgical thrombectomy, it could be catheter-directed thrombectomy or thrombolysis. But reperfusion must start immediately. If the person is at low risk, you consider early discharge and outpatient treatment. Very often we can do this from the ER itself, because when they follow up these patients, they've shown that the risk of having a bad outcome is extremely low. In our places, we very often monitor them for a day or two, make sure that they're stable, no fresh emboli come, and then we send them home. If the person is at intermediate high risk, you must monitor these very closely. Usually we do this in the ICU or in the high dependency unit, and we keep them under close monitoring for need to assess the need for rescue reperfusion therapy. If they're at intermediate low risk, we keep them in hospital and we start in hospital treatment, typically with just anticoagulation treatment. So, as I already mentioned, high risk, you do rescue reperfusion therapy with a surgical embolectomy, especially the person is crashing in front of you, if the person has a cardiac arrest, person has had a syncopal attacks and is having big problems, unable to bring his BP up with standard treatment, rush them into the OT and do a surgical embolectomy. Rarely needed. Very often patients don't even survive to reach this point, but can be life-saving. The second step is to do thrombolysis. The patient gives you time to do it. You can either do a systemic thrombolysis, which is easier even in an ordinary ICU, or you can do a catheter-directed thrombolysis, taking the person into a cath lab, and CDT, catheter-directed thrombolysis, may be more effective than systemic thrombolysis, a catheter-based thrombectomy with or without thrombolysis, or just anticoagulation. However, we don't have strong evidence for this. This is a weak recommendation still, but a lot of cardiac surgeons and cardiologists will swear by this. So I'm not going to go into thrombolysis. We have different regimens for thrombolysis, and many people are using a half-dose thrombolysis after the MOPED study, which I'm not going to go into for lack of time. Obviously, before you give thrombolysis, you have to assess the risk of absolute contraindications and relative contraindications. And if there are relative contraindications, ask yourself, should I do a catheter-directed procedure rather than go to systemic thrombolysis? If a person has intermediate high risk, you monitor in the ICU for decompensation and see whether you need to give them rescue therapy. Then you start on anticoagulation. If they have intermediate low risk, you give them in-hospital treatment, but only with anticoagulation. You don't need to consider thrombolysis. You have several different choices for anticoagulation, and especially after the arrival of the direct oral anticoagulants or the novel oral anticoagulants, NOACs, we have a wide choice. Unfractionated heparin, low molecular weight heparin, fondaparinux, the coumarins, the novel oral anticoagulants, and antiplatelet agents, which are used only when there is an impossibility of using heparin. When should you use a new oral anticoagulant? These days, the latest guidelines suggest that you should use these as first choice, but there are some important conditions. You need to be sure that this person is going to be adherent to treatment. I've had some people who on NOACs came back with a repeat PE and we don't know. They swear they are adherent to treatment, but we're not very sure. There are some patients, despite using warfarins, where you have tried for a long time, you still cannot get good INR control. Obviously, you need to have good renal function and you need to have good hepatic function. So in these people, you can use a new oral anticoagulant. And I'll come back to this later. But when will you avoid a NOAC? You will avoid it when a person is poorly adherent because you don't know if they're taking it or not. You have no way of cross-checking by doing an INR. When they have, as already mentioned, poor renal or hepatic function, if they're on strong cytochrome inhibitors or inducers, because it will play havoc with your assessment of their clotting. Pregnant patients, we don't have enough data. Patients are already on dual antiplatelet therapy because reversing their effects is very difficult. We have an appropriate reversal agent and antidote only for dabigatran. And of course, if a person has cancer, the latest guidelines say you can use NOACs, especially apixaban and rivaroxaban in patients who have cancer, because we have data for these. Having decided to anticoagulate, and please remember that you must start a person on a parenteral low molecular weight heparin, unfractionated heparin, fondaparinux, or one of these. If you're planning to use warfarins, because warfarins initially increase the risk of coagulation, take about 3 days to really have their action, during which time the person is in continued risk of having a further pulmonary embolism. So such patients, you have to start by using heparins. However, if the patient is on a NOAC, you can straight away start using a NOAC. How long do you want to anticoagulate? So typically we used to say 3 to 6 months of treatment, and various studies have shown that perhaps 6 months of anticoagulation treatment is the one that is most commonly used. If a person has a clinically symptomatic proximal DVT or PE, they have given 6 months of treatment and then discontinued anticoagulation and followed for recurrent DVT or PE. And we know that if the first PE was unprovoked, there were no obvious factors such as surgery, immobilization, cancer, and so on, then the risk of having a recurrence is much higher. If a person has a provoked PE, on the other hand, the risk is less, though not zero. And I'll ask you to remember this, the risk is lower, though not zero. So how long do you want to anticoagulate? We usually give it for 3 months. And there were some studies like the prolonged 1 and 2 study and the annual study where they carried it on for a year to 18 months. What they did was they did a D-dimer 1 to 2 months after stopping the anticoagulation. The prolonged they did one after the first negative D-dimer, they did 1 2 months later. If the D-dimer was high on the repeat test, then there was a 15 to 27% chance of having a repeat pulmonary embolism. On the other hand, if the person had a low D-dimer, the D-dimer was negative, then there was a much lower chance of having a recurrent pulmonary embolism. So essentially, what I do, and based on all these studies put together, is anticoagulate them for 6 months if it is a provoked PE. If it is an unprovoked PE or the person has a previous history of pulmonary emboli, I just continue anticoagulation long term. If the patient has risk factors, obviously you need to think this through. You discuss it with the patient, and the person has a low risk, you might choose to stop it. If the person says, I will follow up very carefully, you repeat a D-dimer after 1 month. If the D-dimer is high, and this has happened with a few of my patients, you discuss it with them and restart it because they have a 1 in 6 to 1 in 10 to even 1 in 4 chance of having a recurrent PE, and this may be life-threatening. So, in short, males, females, slight differences, we won't get into that. And in the elderly, you always have to assess the risk of bleeding. Based on this, you take your decision on whether to continue anticoagulation after 3 to 6 months or not, or to restart anticoagulation. As already mentioned, low risk early discharge and outpatient treatment. And I'm not going to go into this because they followed up these patients who are at low risk and found a very, very low risk for recurrence of PE in the outpatient. Indications for an Ivc filter, vascular surgeons love to put this in, but in short, you do it only when there is a definite contraindication to anticoagulation, or you're very worried that the person might have a massive PE while waiting, maybe a very unstable clot sitting in the IVC, looking like it will break off anytime. You can put in a Ivc filter, which is these days retrievable. You can always take it out when the risk subsides. So, last few slides on the COVID era, we know that there is an increased risk of venous thromboembolism in patients with severe COVID. 25% to 43% have had clinically relevant thrombotic complications, mostly pulmonary emboli, but also other things. And this is also in patients who are renal replacement therapy and ECMO, there's a very high risk of clotting events. So the risk you can see in comparison with ARDS patients in a non-COVID era, it is 11.7% versus 2.1%. So almost or more than a 5-fold risk of developing thromboembolic complications in patients with severe COVID-19 as compared to non-COVID-19 patients with ARDS. So there are various different anticoagulation regimens going on. I'm not going to discuss this because we don't have these very definitely yet. The bottom I've put our regimen. You can always review it later. And the Mount Sinai, I like the Mount Sinai COVID anticoagulation algorithm. It's more complicated, but I think more comprehensive. We simplified it for ease of use. So I'll stop with recommendations that came from the European Society of Cardiology last year. It said that in patients who deteriorate hemodynamically, you need to use rescue thrombolytic therapy. Consider surgical embolectomy or catheter-directed treatment as alternatives in patients who deteriorate in front of you hemodynamically. D-dimer measurement and D-dimer measurement and clinical prediction rules should be considered to rule out PE during pregnancy or in the postpartum period. Further evaluation may be considered for asymptomatic PE survivors at increased risk for CTEPH. and I'll come back to this a little later. You should always interpret the D-dimer in association with the age-adjusted cutoffs, because we've learned that D-dimer varies with age. You should also adapt it to the clinical probability. So you must always assess the pretest probability and don't use a fixed cutoff level. If you've used a chest ultrasound to confirm a PE and you pick up a proximal clot, then risk assessment should be considered to guide management. And of course, you can continue a VQ SPECT, which is not available in most places for PE diagnosis. Always assess the RV by a combination of imaging and lab biomarkers, even if you have a low PESI score or an SPESI score of 0. Use a validated score, which combines clinical, imaging, and lab prognostic factors to use to classify the PE severity. When you start treatment in the acute phase, use oral anticoagulation in a person who's eligible for a NOAC. And a NOAC is the recommended form of anticoagulant treatment if there's no contraindication. So that's a change from the 2014 guidelines, where it was given as an alternative. If possible, use multidisciplinary teams to manage these patients, especially the high risk and intermediate high risk patients. You can consider ECMO in combination with surgical embolectomy in cases of cardiac arrest or circulatory collapse. Chronic treatment and in prevention of recurrence in patients without cancer, consider indefinite treatment, consider extended anticoagulation if there's no identifiable risk factor, consider it in those with a persistent risk factor other than the APLA syndrome, where you anyway have to give it, extended anticoagulation for patients with a minor transient reversible risk factor, which you think may not be a risk factor. Why did this guy have to get it with so little of a problem? Consider giving them extended anticoagulation, and consider after the first 6 months reducing the dose of apixaban or rivaroxaban. So you may move from apixaban 5 mg/BD to 2.5 mg/BD. In patients with cancer, consider one of these, edoxaban or rivaroxaban, as an alternative to LMWH. In pregnancy, consider that it may not just be a pulmonary embolism, but also an amniotic fluid embolism, and consider thrombolysis or surgical embolectomy if the person is at high risk, though it is a risk factor. But NOACs are not recommended during pregnancy or lactation because we don't have enough evidence. Routine clinical evaluation 3 to 6 months after an acute PE should be done, and I'll come back to this a little later. Integrated models of care, as already mentioned, to go from an acute PE to hospital or ambulatory care. And if patients on a VQ scan continue to have mismatched perfusion defects when you do a VQ scan or a CT scan, then refer to a center with experience, expertise in managing CTEF. A few lines on acute to chronic pulmonary embolism. So normally what happens when you have an acute pulmonary embolism, it's happened because of a prothrombotic state, temporarily or permanently, is it usually resolves. But if there is failure of fibrinolysis, it goes on to develop obstruction and gets organized. This is due to inappropriate organization. And this leads to pulmonary hypertension, which being chronic is called chronic thromboembolic pulmonary hypertension. And this leads to various sequelae. There's no time today to talk about CTEF. It's a whole topic by itself. But I'll just take you through a few slides. We did a study several years ago which looked at all our patients with acute PE and showed that 6 months later, a lot of them had CTEF. We now realize, we earlier attributed it in our paper to poor anticoagulation, which may be part of the answer. But we also realize these days that a lot of patients who presented with acute PE already had CTEF. And this has been missed because the acute PE dominates the clinical picture, it dominates the CT picture, and unless you look carefully, you will miss underlying chronic thromboembolic pulmonary hypertension. Why is this important? It's because these patients obviously have worse outcomes, but also it tells you that you need to anticoagulate these patients for life because they've already had previous PEs, and you must assess them for surgery in the future. So this is something we've learned over the recent past. So nowadays, every single patient with acute PE, we also look for evidence of chronic thromboembolic disease underlying that. I'm not going to go into these, but just to tell you that there are some features. If you see already, like our patient, a widened PA compared to the aorta, if you see evidence of peripheral wall adherent clot as opposed to central clot like this, so this patient had a web and this patient had a peripheral eccentric clot. These are chronic PEs rather than acute PEs. Some of them will also have acute PEs along with it, like this patient did. And this patient had an acute PE associated with a chronic PE. So patients can have both in the same patient, an acute pulmonary embolism like the central lesion, as well as a peripheral wall adherent lesion like this, telling us that both are possible in the same patient. And one of the things that often gives us the clue is the presence of chronic bronchopulmonary collaterals between the aorta and the bronchial or pulmonary arteries. These collaterals run and do not occur for at least 2 weeks. So it tells you that this cannot be an acute PE. This is probably a chronic or an acute on chronic PE. And you can see beautiful examples of these collaterals if you look carefully enough in a late phase. So it's very important that your scan is done in an early pulmonary phase as well as in an aortogram phase. So you've got to work with your radiology team to ask them for a comprehensive 2-phase CT pulmonary angiogram. And this is what happens. Why it's important is in primary pulmonary hypertension or idiopathic pulmonary hypertension, you only have the intercostal arteries. You don't have the collaterals that you're seeing in patients with CTEPH. So to summarize, you suspect pulmonary embolism based on the background, symptoms, and sign. The background is very, very important to raise your suspicion because symptoms and signs can often be misleading. The next question you ask yourself is the patient stable? If the patient is unstable, you rush into imaging and or treatment straight away. If the patient is stable, you first do the pulmonary embolism rule-out criteria, which, as I already told you, looks at risk factors. If the person is negative on all 8, then you apply as a safeguard another score, such as the simplified Geneva score or the modified Wells score. In all patients, you will also do a D-dimer if your clinical suspicion was high, irrespective of what the Geneva score is. So you do a D-dimer, and then you go on to do the CT pulmonary angiogram or a VQ scan or both. You follow this up with another form of imaging, which is the 2D echo, looking for evidence of RV dysfunction or sometimes direct evidence of clot. And you also do the biochemistry while you're waiting, and you do a tropi or a TROP-T, a natriuretic peptide such as BNP or NT-proBNP, or the heart fatty acid binding protein. Based on this, you do a risk assessment, and then you go on to do the appropriate treatment. High risk, immediate reperfusion strategy. Intermediate high risk, monitor carefully in the ICU if need be, and start thrombolysis. This could be either systemic or catheter-directed thrombolysis. Intermediate low risk, you admit, give them anticoagulation and watch carefully. Low risk, you send them home, maybe after admission to an ordinary ward for a day or 2. Ensure that there are no recurrent emboli, which can cause a problem if the patient goes home. Start an anticoagulation and ask them to continue anticoagulation. Review after 3 months of continued anticoagulation, monitoring the PT-INR if you choose coumarins. No need to monitor this if you're using a NOAC. And after 3 months to 6 months, depending on whether it's provoked or unprovoked. If it is unprovoked, you can continue long-term. If it is provoked, stop the treatment, review after a month, do a D-dimer, D-dimer elevated, restart anticoagulation, D-dimer not elevated. You can ask them to just continue care and monitoring at home. Thank you very much.
I'm wearing the same shirt since last evening.
Good for you.
Okay, fine. Murli, that was great. And whenever I hear your talks, the only thing which crosses my mind is how unfortunate you are that you can't be in the audience when you are talking something. So we are so lucky to listen to you and the way you present. Everyone knows everything about most of the things, but the way you present it and the way you simplify it and the way you make it easily digestible, it's like a buffet of all the fruits mixed so well in a grinder. You drink it and it's immediately digested. Amazing talk. So we'll just straight off go for questions, Murli, and I'm getting a huge number of questions. What I'm going to do is I will start from the PE and association with other respiratory diseases and come to the acute presentations. And of course, then I will take questions on the COVID-19. So we have one question by Dr. Tridib Chatterjee from Mumbai as to how often do we see chronic PE as a comorbid associate in moderate and moderate to severe COPD, say a grade C and the grade D. Do we see it often, or is it more often missed than it's diagnosed?
So I think it's more often missed. We know from studies in the past that 9 to 10% of patients presenting with an acute exacerbation of COPD actually have underlying pulmonary emboli. So that is the problem, 9 to 10%. And this has been shown across multiple studies. So I don't know if there's a study showing the association with group C and group D, but I know it happens in acute exacerbations. And I think there was even a study from Bombay, Zarir Udwadia, and I think this was, Dr. Tiash Sen, who was working in Bombay with Zarir. This was her dissertation. And she again showed roughly the same figures. 9 to 10% of patients with acute exacerbation of COPD actually have underlying pulmonary emboli. So it is a combination.
What about the probable incidence of chronic pulmonary thromboembolism in patients of COPD, and thereby what would be the role of other drugs in treating COPD, say Riociguat for that matter? Are we kind of missing even chronic Ps in COPDs?
I'm sure we are. If 9 to 10% have acute PE, about 3% of these 10% would not resolve properly. So we're talking about something like 0.3% of COPDs will have some evidence of CTEPH. The problem is, again, it's lost in all the structural damage that a COPD causes. And very often we don't do CT pulmonary angiograms. We may do a CT plain and contrast, but we don't do it with a correct PE protocol. And it's very important. Just doing a contrast will miss a lot of PEs, especially chronic PEs, unless you do it with the right protocol. And we've seen this happen repeatedly. I mean, the first case that I showed today, he had a contrast CT, but it did not pick up the pulmonary emboli because these were small, segmental pulmonary emboli. So if you do it with the proper protocol, you'll pick it up much better. And that's a thought. I've actually never thought about this, but I think you're absolutely right.
Because so many patients with COPD, which we see, we do an echo, we find pulmonary hypertension, and with whatever reservations the most of the authorities have, we see prescriptions of sildenafil in COPD far more often than what we should be seeing. And quite a few of them do get better. I really don't know why should they get better. They should actually be worsening, but they do get better. So are they treating, are those getting better, are those with a subset of chronic PE, which is getting better, and probably they would be better served with Riociguat instead of sildenafil? So that needs to be pondered, and what would be the best modality to actually investigate such patients, because it's going to be very peripheral. There is a lot of structural distortion. So even if there is chronic PE, probably we will not be able to pick it up even if we were to do a good CT.
So I think, obviously the gold standard is a pulmonary angiogram.
Yeah.
But a CT pulmonary angiogram these days works almost as well.
Yes.
This is a group in which it becomes very difficult to interpret a VQ scan. So as I said during my presentation, if you know that the person has structural lung disease and an abdominal X-ray, go straight for a CTPA. And I think that's the best, but you need to have it done by a good person, in a good center, interpreted with great care. And that's very important.
And most important is the index of suspicion.
Absolutely. Very, very important.
So let's now move from COPD to other chronic disease. Say now you have an established chronic pulmonary thromboembolism. How often would you investigate them for connective tissue profile? This question comes from Dr. Pradeep Kumar Dasri from Hyderabad.
100%. Everybody with CTEPH gets APLA and an ANA. Apart from doing a thrombophilia profile. Unfortunately, we can't often do a thrombophilia profile because patients are already on anticoagulants, so you can't do the antithrombin 3, protein C, protein S, and so on. But you can certainly do the ANAs, APLAs, and homocysteine levels. These still have some value. And you can do the factor V Leiden, of course.
Now let's come to the acute presentations. If someone comes in the question comes from uh, Dr. Vijay Kumar Chetty. Like, this patient comes in an emergency room and with some RV dysfunction. So, and essentially normotensive, hemodynamically stable. What would be the role of thrombolysis in such patients?
So if a person has an intermediate high risk, I would certainly consider thrombolysis. And more we find that that is the way we are going, not just for the immediate outcomes, which may be okay, you can get away with just anticoagulation in these people. But, some of us believe, especially my chief radiologist who heads our pulmonary vascular group, Professor George Cherian, believes anticoagulation, especially if it is inadequate, can lead to CTEPH in the future. Whereas if you thrombolyze them, the risk of CTEPH in the future comes down. So if we have somebody with intermediate high risk, we very often thrombolyze. If they're intermediate low risk or they have any contraindications, we just anticoagulate them. And this can start in the ER, as Dr. Vijay Kumar Chetty said. And by the way, thanks, Dr. Vijay Kumar. Excellent backstage work you've done in organizing all these masterclasses.
So now I will ask the true question which Dr. Vijay Kumar posted. I took the moderator's liberty in twisting that question around. Now the true question is, if someone who is COVID positive comes into your ER with RV dysfunction, would you then thrombolyze him? Now we know what COVID does, and he has RV dysfunction.
I have not had that experience yet, but I probably would not. For the simple reason that we are seeing a lot of patients with hemoptysis in this group, and we don't know what is causing the RV dysfunction. This algorithm refers to RV dysfunction when it occurs due to the clot. Whereas if it is ARDS due to COVID or otherwise, that may be causing the pulmonary hypertension, the RV dysfunction, as well as the hypoxia. And that is not going to be helped by thrombolysis. So as we were discussing a little earlier, it's a risk-benefit ratio. And here I'm not very sure that the risk-benefit ratio is in favor of thrombolysis. In such a patient, I would probably just anticoagulate rather than thrombolyze.
The question basically
comes. One has to keep an open mind on these things and be prepared to reverse that decision at any time.
Correct. Why I'm asking you about thrombolysis is, like, we have the golden hour in cardiology. Do we have this concept of golden hour in pulmonary thrombolysis and reperfusion therapy?
Not really. No.
Would we be missing the bus if we were to delay the decision of thrombolysis?
Because fortunately, the clot remains dissolvable. And distal to that, most often the perfusion is preserved by the bronchial circulation. So you don't have to worry too much, unlike the cerebral arteries, for example, which are end arteries. You block them and it leads to permanent damage, and the brain is extremely, extremely sensitive to hypoxia. The heart, you have a little more time, but even that is sensitive because all the coronary vessels are most often end arteries. We don't have that problem with the pulmonary circulation. So that's one of the good things. You have a little time to work. We've done thrombolysis even 2 days after the initial onset of symptoms and got extremely good results. But the longer you wait, the less good the results are. But it's not a golden hour or a golden 6 hours.
Yeah. So basically, we are not in as much as rush. Of course, we do it ASAP if things are very diagnostically clear. But it is not that golden hour miss and you miss the bus.
Most patients reach us much later anyway.
Yeah. So now, any experience of association with PE with sleep disorders? Is sleep disorder a trigger mechanism which can cause endothelial dysfunction and thrombotic complications? And if so, if patients with moderate to severe sleep apnea and moderate pulmonary hypertension, what would be the role of anticoagulants in such patients? So this question comes from Dr. Prasanna Kumar from Bangalore.
Excellent question, Dr. Prasanna. This is my belief, and there are a few studies showing that in every patient with sleep apnea, you must keep in mind that they are at risk for pulmonary embolism. And vice versa. When you have a person who presents to you with a PE and no obvious risk factors, it's very important to look for obstructive sleep apnea as being one of the underlying risk factors. What I would do is not start every patient with OSA on anticoagulation, but I would investigate for the possibility of OSA in patients with PE and look for pulmonary hypertension being caused by chronic thromboembolic pulmonary hypertension in a person with OSA, especially if the pulmonary hypertension or the pulmonary pressures are disproportionate to the severity of the OSA. So, you have somebody who's not hypoxic, does not have significant,
Index and
polycythemia or anything,
desaturation.
and they're not dropping their oxygen too much at night. Though they are dropping it, it's still in the 88, 86 range. They're not going down to the 50s and 60s that we see sometimes. Their total time below 90% is not very long. And yet these guys have very severe pulmonary hypertension. Look for a pulmonary embolism in these patients, especially CTEPH.
So summarizing, if you can't really develop a cause and effect relationship between the pH and the OSA, look for something else which is attributing to the worst pH, and that possibly could be chronic pulmonary embolism.
Exactly. And this applies across all the pulmonary disorders. Which is disproportionate, look for this.
Yes. So there's another question coming from Dr. Satyai Tayade from Mumbai. Like, in case you put an IVC filter in acute PE, how long would you keep it? How long would you keep it there? 6 months? 1 year?
No, much shorter than that. What you've got to be sure is you've got this person either thrombolized or anticoagulated adequately. You've shown that the clots have disappeared, so you might follow up with CTPA after 2-3 months. And now you don't. And by the way, whenever you do a CTPA, it's very, very important that you also ask for a venogram, which is an extended phase. And, if you can image and show that there's no clot remaining, it's a good time to take out the IVC filter.
Is there a time frame which you have in mind, which would be, say,
I usually would wait at least 3 months because it will take that time for any reasonably sized clot, which is why you put in the IVC filter to take it out. On the other hand, if this is a person you put in the IVC filter for anticoagulation being contraindicated, then you just leave it in long term.
I couldn't understand this question well, but Dr. Ajoy Memin from Thiruvananthapuram says, I believe what he's trying to ask is, when would you be ambulating a patient of pulmonary embolism in a case of DVT? And when would you be starting to ambulate this patient after you initiate the therapy? I believe that's the question, what he's trying to put across.
Good question. Again, no answers to that. No guideline or book gives you an answer to that. You only go by gut feeling. You feel you've got this guy anticoagulated enough. He's not likely to throw another embolism from his leg. The signs of DVT are starting to subside. I would probably be careful, make sure the guy is not going to massage his leg and, squeeze the clot out. But I would start ambulating then. Because if you keep them non-ambulatory, they suffer greater problems in the future. So I usually wait for about 3 days. And by the end of 3 days, they usually, the acute signs are starting to subside. You got over the worst of it. And if it's not broken off in those 3 days, it's not going to break off with, just ambulation. So usually about 3 days and we start limited ambulation.
What happens with the gastrocnemius and the soleus, they being the peripheral heart, even if they start exercising with more brisk walks, that almost acts like the massage, which releases the shower. So ambulation should be just ambulation, just moving around. It should not be a rapid contraction and a relaxation, which can literally push the thrombi further. So Dr. Prasanna Kumar again from Bangalore wants to know, how frequently do you see CHF and vasculitis, and how long would you be anticoagulating them? If it's vasculitis, Apla, Anka, and you have, so is it going to be a lifelong anticoagulation?
So with Apla, definitely lifelong. With the vasculitides, whether it's anchor positive or anchor negative, you go by what you're seeing. These patients very often have arterial thrombi, not just venous thrombi. And you've got to make sure that you've got the primary disease under control. So if you've got the primary disease under control with whatever you're using, whether it's cyclophosphamide or rituximab or whatever, and you're confident that the disease is under good control, you can withdraw the anticoagulation.
The primary disease by itself also needs to behave in a quite phasic manner. So
it does.
Would it
so you've got to keep
underdoing
those follow-up and consider that if there is ongoing thrombosis, then you restart the anticoagulation. Such patients often we just keep on antiplatelet agents
So in a
because the risk
disease,
of keeping them on anticoagulation for too long is also there. So you always do a risk-benefit analysis.
in a disease like APLA, where you're going to anticoagulate them almost lifelong, would you be with a conventional warfarin or NOACs upfront?
So I'm a bit old-fashioned, and I'm very heavily influenced by Professor Cherian, who's seriously old-fashioned. He's taught me so much, so I follow his footsteps. We tend to believe in the remember that in APLA, in anchor vasculitis or non-vasculitis, the NOACs have never been shown to be effective. There are no trials with these. So we tend to use in these, but in provoked, it's a different one. In unprovoked and in those with an underlying connective tissue disorder, we prefer to use the old-fashioned warfarins.
So the case for warfarin and the conventional anticoagulants in completely unprovoked disease like APLA, and where you have to really be very serious about anticoagulation because a slight modification can lead to disastrous consequences. It's better to rely on the well-tested medications and which behaves in a more predictable way.
And you're able to monitor it, which is important. You can't do that with NOACs.
So I have been specifically keeping all the COVID questions aside. I'll ask you together. Let me check if there's anyone who wants to ask anything beyond COVID. Okay, fine. So here's one question from Divya Jain from Trivandrum, that in a case with intermediate or low risk of pulmonary embolism and hemodynamically unstable enough to be shifted not for imaging, can we start anticoagulation straight away?
Absolutely. If your clinical suspicion is high and the person is unstable and you're sure that the instability is due to a PE, certainly not just anticoagulation, you can even start thrombolysis once you've gone through the checklist of ruling out all the absolute and relative contraindications.
I suppose that answers the question explicitly. So now let's jump on to the COVID bandwagon.
And Kumar, I think you have better experience with this, so I'd invite you to come in on answers to these at the same time. I will do my best to answer, but please do feel free to jump in at any point.
Yes, any point. So let's start with basics, like what does COVID do which other viral infections or other bacterial infections do not do, which leads to this so much of thrombotic complications?
So there are two things that we generally talk about. One is the inflammation. And as I mentioned in the course of my talk, inflammation is bound up with the immune system. Inflammation is bound up with the thrombotic system or the hemostatic system. Very, very important. So whenever you have inflammation, and the more the inflammation, the more risk of thrombosis. So that is the simple, straightforward answer, but doesn't answer why in COVID we see so much more of this problem. For that, you must go into a very nice paper, very small paper, which was based on autopsies and histopathology, but beautifully demonstrated that patients with COVID seem to have endothelialitis. So there's an active inflammation, which is one of the important criteria of Werkhoff's triad. Changes in the vessel wall, so there's endothelial dysfunction. The second thing that they're describing is something they call intussusceptive angiogenesis. So you actually have ingrowths of the endothelium within the lumen of the small vessels, the capillaries and the arterioles. And what this does is twofold. One is it slows down flow because you're having a septum put across. So obviously the vessel becomes narrower. And now this is an inflamed septum, so it makes it even more sticky. And therefore that leads to thrombosis. So the microthrombosis occurs at these because of these multiple causes. And that seems to be very peculiar to COVID. They've also described some strange outgrowths, which, the virus provokes the cell to produce. So obviously that will work like a brush border where you don't want that, you want a smooth flow through it, and that is not happening. So perhaps there are some reasons. Now, the caution in all this is these are autopsy studies. We don't know how many of these changes have occurred during the processing and the reading. So that's a caution we need to take. But undoubtedly, these are beautiful images that we are seeing and may explain what is happening.
So I have a slightly more simpler take in COVID and lung, it primarily ends up inflaming every single component that we know in the lung. It inflames the interstitium, it inflames the alveoli, it inflames the microvasculature, and then the consequences of thereon and therefore so forth. We are now seeing very distorted and grossly interstitial lung disease at the end of a month or so, which are not getting better. And it's only some time before somebody goes and does a cryobiopsy on such patients and gives us live patients' biopsies as to what is actually happening inside the lung before we can comment on this. So the question number one is like COVID is for some reasons prothrombotic, and thrombotic complications within the lung are a very large part of the cause of the whole hypoxemic respiratory failure. And this is where Dr. Chabra from Delhi is
What you
also
said,
having a
Kumar, these
yeah.
thrombotic complications are not restricted to the lung, as you mentioned earlier. They're all over the body.
Yes, all over the body,
Spills
all
over
over the
into the
body.
whole
Yes,
system.
as we discussed earlier.
Yeah.
So Dr. Chabra from Delhi also has a comment on that. He actually hasn't really come across significant numbers of high or intermediate risks PEs in COVID patients. Probably these are subsegmental or multiple producing severe hypoxia, but not much severe pulmonary hypertension. And I completely agree with him. Like so many patients who are coming with severe hypoxia in the ICUs, and we went around doing echoes for everybody to pick up something. If I can pick up pH and I can maybe give sildenafil to improve their oxygenation, none. We hardly picked up any pulmonary hypertension. What about you, Dr. Mohan? Could you
So we have
see such severe pHs in?
So I will defer to Professor Chabra and you because we have just started our surge of COVID. So we don't have enough wide experience of it.
Okay.
But what I can say is that, it's not a common complication, but we often hear of people who seem to be well, went home and dropped dead.
Yes.
So sudden cardiac death, and for that, obviously a pulmonary embolism can be one of the explanations. It's not, as far as we know, that's not the only explanation. It could be cardiac, it could be anything else, it could be a dysrhythmia, but that certainly should be something we keep in mind. So I think it's very, very important that we don't say nobody will have these complications. I think a significant number can, and especially
we keep our eyes and ears open because actually we are still in the middle of the pandemic and we really don't know how the whole thing is going to pan out.
We also remember that, we are seeing different clinical presentations in the West and here.
Yes.
What they're describing in the West may not be what we are seeing here at all. For whatever.
In fact, I have strongly believed, as I was discussing with you earlier, that if we probably were so research oriented and we had the resources, probably by this time we would have even come out with an answer why our presentation, the number of patients and the number of deaths is so dramatically different from the rest of the world, as we were discussing. But unfortunately, we haven't been able to provide a very convincing answer to the world as to why we are somehow better off. So again, COVID and
that is Professor Chabra is starting off a registry.
Yes, we should be able to get some answers. Yes,
get some good answers.
Yes, yeah. So again, COVID and thrombosis. So we are all giving them low molecular weight heparins based on the D-dimer at this point in time. First question would be, what would be your take on starting them on NOACs upfront in hospital, or to those patients who have elevated D-dimers, moderate disease, and are unable to find a bed in the hospital but deserve anticoagulation and are not able to take low molecular weight? How do we circumvent around that problem? Your take on NOACs upfront before low molecular weight?
I would start NOACs if there was no way of giving low molecular weight heparin. My preferred choice would be LMWH. If you can train a person to take it, the person is used to taking insulin, for example, you tell them it's exactly the same. Pre-filled syringes are available, so there's no great problem with that. If they enter hospital, certainly my preferred choice is low molecular weight heparin. If I have to treat them at home, I'm happy for either one of them. And all our patients who in hospital get a low molecular weight heparin go home on a NOAC.
Any particular choice in NOAC?
Sorry? No particular choice. We usually use dabigatran because it's got a reversal agent and it's, we are most familiar with it. But we also are very fond of using apixaban because you can use lower doses of it.
So this was another question from Dr. Tridib from Mumbai, and while treating CTEPH and when we are giving NOACs to the patients with chronic pulmonary thromboembolism, your choice would be dabigatran and apixaban,
Those are
one
the
over the other.
usual, yeah, no, there's no particular choice of one over the other.
Okay. No.
Again, with dabigatran, you have the advantage of 110 versus 150. So, a prophylaxis versus a therapeutic dose. So that remains, so either one of them is fine.
So how long would you be giving the patients anticoagulation post-COVID? Say a moderate case or a severe case? Because this is a burning question, and apparently I am seeing varied prescriptions. If I know a prescription is coming from hospital A, he would be on dabigatran. If I know the prescription is coming from hospital B, he will be on Eliquis for 3 months. And if I know that prescription is coming from hospital C, he would be on nothing at all. So there seems to be a very varied ideas about anticoagulation in COVID. Can we make some rational can we give someone a rational pathway as to, number one, which patients to give post-discharge anticoagulation and which patients to give for how long?
So I think we should base it on what looks like the severity of the inflammation, because they seem bound up together. So I wouldn't go only by the D-dimer, because D-dimer has so many different, factors influencing it. So what I would go by is what is the level of inflammation and what is the level of risk. If we find that this is a person where the CORAD's 4 or 5, if a person has had a stormy hospital course, needed to be on a ventilator very long, I'd probably continue it for at least a month and a half, 6 weeks. And I would not be averse to continuing it for 3 months if the person is taking it without any problems.
So ventilated, you mean non-invasive ventilation or high-frequency nasal oxygen as well? Any form of high-flow oxygen?
Yes.
So if would it be safe if I were to comment on this platform that it would be recommended if we were to continue about 1.5 months of anticoagulation if the patient had a disease severe enough to require very high-flow oxygen, stroke NIV, stroke invasive ventilator? Would I be correct on that?
That would be my personal opinion, not backed up by any evidence. Professor Chabra and I have been having this to and fro as what is the right time. And I don't think either of us can point to any definite evidence.
I wish Dr. Chabra can comment on the question, probably because there is no way to connect with him on this.
Yeah. So he'll probably send in a comment later.
So let me tell you the other way around. Is there a place for anticoagulation for the mild or the moderate disease who have been just requiring 2 or 3 liters of oxygen therapy and doing extremely well? Is there a case for anticoagulation for such group of patients at all?
So I would keep them on low-dose anticoagulation and a low-dose prophylaxis. For example, as we discussed, apixaban, Eliquis in a 2.5 twice daily when they go home. But I believe they should be on some form of anticoagulation.
How long would be that for?
For 4 to 6 weeks.
4 to 6 weeks.
Yeah. Most probably just 4 weeks, but not 6 weeks.
Oh, so now the questions, I'm so happy. Now there are other questions apart from COVID. So that's great. So Dr. Shamal Sarkar from Ranchi is, what would be the duration of NOAC therapy if a follow-up Doppler shows persistence of thrombus elements in case of a DVT?
Very often you will find fibrotic veins, which it's very difficult to tell the difference. So I think we can see you. And I could hear you, Kumar.
Yeah, I can hear you now.
Yeah. So since you see fibrotic elements, it's very difficult to separate these from, persistent clot. So I would say I would go by the original formula that we used. Provoked clot, 3 to 6 months. Wait a month, repeat the D-dimer. I would not go by what the Doppler scan is telling us, unless it can pick up on, fresh clot and things like that. In which case, is this merely a recurrence of the DVT? In which case, I would restart the anticoagulation or continue the anticoagulation for long.
Okay, so a question pertaining to our earlier discussion on OSA and COPD. Would you routinely ask for a CT pulmonary angio in a patient of a severe COPD having significant hypoxia or OSA with PH, irrespective of it being explained by the severity of the OSA? Would you
No, I
routinely
won't.
ask for it only if you see a disproportionate disease?
Yes, only if I see a disproportionate
So I
amount.
suppose this question was from Dr. Pradeep Kumar Dasre from Hyderabad. I suppose this answers this question as well. I have Dr. Prasanna Kumar has a question on if a patient of sleep disorder goes into cor pulmonar. Now, this doesn't mean that it's a disproportionate disease, but he developed PH and now in cor pulmonar. What is the role of anticoagulants? We are not kind of investigating whether he has CTEP or not, but would you anticoagulate them? That's his question from Dr. Prasanna Kumar from
No, I
Bangalore.
don't think so. Not unless he is at high risk for PE for any reason. He is badly immobilized, unable to move around. So these patients you could probably consider a low dose of anticoagulation, but that is not because of the cor pulmonale, not because of his underlying lung disease. It's because of his immobility. I don't think there's any evidence that anticoagulating patients with cor pulmonale alters outcomes in any way.
So now let me come back to COVID and my personal problems and experiences with COVID. Like we have divided this disease with mild, moderate, and severe on the basis of clinical presentations and oxygen levels going down or the X-ray showing some shadows. None of the descriptions use CT scan for the severity of the disease, though most of our patients get a CT scan. It is very difficult to have a very strict line between a mild and a moderate disease. At what point, what clinical point, when you are, I'm not asking about a public guideline, which will be different from individualized and a personalized medicine. At what clinical point would you initiate a patient who is COVID positive with just fever, maintaining saturations otherwise? Would you initiate anticoagulation? Just a drop in the saturation by 3 points from the baseline showing mild hypoxemia, or a CT showing CORADS is, he's already positive, so I'm not worried about CORADS, but a severity score of significant severity score would you start? Are there any objective criteria which will help you to decide that this is the point I want to start anticoagulation, which may not be in consonance with the national guidelines or international guidelines because it's individualized and personalized?
Yeah. So I believe, this is my personal belief, not guideline. Everybody should be on some form of anticoagulation.
Even mild?
Even mild, as long as they, not mild, but moderate, because they've dropped their oxygen level. Okay, that was your definition, 3% drop from baseline. Yes. So that straight away puts them into a moderate group at least. Moderate. Yeah, and if such patients have a greater than 50% involvement, this is what we've done for our own hospital guideline. If there is greater than 50% involvement of the lung, you've gone through lobe by lobe, yeah, then you probably will aim for a higher degree of anticoagulation. Similarly, if they have a very high D-dimer, you aim for a higher degree of anticoagulation. So again, there is absolutely no evidence for this. Okay, but if you look at the Mount Sinai protocol, they use a cutoff. Various other Western hospitals have used these. Again, not backed up by evidence, but with the assumption that the greater the inflammation, the greater the risk of thrombosis. And I think that makes sense, though it is not evidence-backed.
Yes. So anticoagulation is going to be an inseparable part of COVID treatment, as we have learned. And what we have learned is the way the recovery trial showed that dexamethasone works so well. As I said, like to me, COVID is just pan inflammation in every single component of the lung. I see no reason why an anti-inflammatory cannot reduce inflammation in the endothelium as well. So really don't know whether all these patients who are on anticoagulation, by definition, once it's moderate, it's just not anticoagulation. When you are on anticoagulation, your patient is on steroids as well. So we really don't know what is working at what level. But as you rightly said, that the line between mild to moderate has to be moment your saturation drops. Not only at rest, but even if you are dropping saturation on exertion, he may be at rest 96, but if he's dropping down to 92, I believe we should be qualifying and classifying them as a moderate case, such that we can hit early and prevent all the thrombotic complications.
In fact, that's the advice we give our patients.
I'm actually still waiting for Dr. Chabra's comment on the message.
Has it come?
Dr. Anvesha Tamula from Hyderabad, he wants to know about the anticoagulation treatment protocol for COVID patients. I guess we just discussed that we start it in moderate as defined by resting hypoxia, or even if there is hypoxia on exertion.
I'd agree with you.
And D-dimer doesn't come first here. It's hypoxia, it's the involvement in the lung parenchyma if you have an access to CT scan, and if D-dimers are also elevated. So, and also we need to all remember that we have seen elevated D-dimers even in mild patients. So, and we all know that D-dimer can be elevated in any form of inflammation.
Absolutely.
So it doesn't mean that elevated D-dimer is thrombotic. So you have to look at the whole picture before you go hammer and tongs with anticoagulation.
And in fact, CRP may be a better measure than D-dimer.
Come again?
I said CRP may be a better measure than D-dimer to reflect inflammation.
Yes, yeah. So, so Murli, you want to add anything beyond what we have discussed? I guess we have touched upon all the aspects of thromboembolism. Okay, last question on D-dimer. That's my favorite with such a beautiful negative predictive value. How often have you come across a negative D-dimer and yet the person has PE?
Very, very rarely. I have come across it, but extremely rarely. If you look at some of the reports, they suggest as high as 15% in some reports, but I think that's an overestimate. I think it's an extremely good for its negative predictive value, as you rightly said, but I have come across the occasional case. Whether it was a lab error, whether it was a sampling error, I have no idea. But if you know, what you started out with by saying, your clinical suspicion is high, go by your clinical suspicion. Don't be led away by a D-dimer which is not.
And always follow the golden rule in medicine that treat the patient and not the values.
Absolutely right. You know, the most important rule.
So it was amazing talking to you and catching up with you, Murli. Maybe hopefully soon face to face. I, in the depth of my heart, thank CCI, Dr. Krishna, Dr. Nagendra, Dr. Dosi, Dr. Chennam Chetty to have put up this wonderful program. And of course, being at the helm of affair of such a wonderful group, the Chest Council of India, extremely active in academics, in social, in music, and we have all sorts of groups, and it's been a pleasure to be a part of this group. And of course, it has been a pleasure to be a part of today's symposia and moderating. And moderating whom? Murli, wow.
No, and thanks to you. Much. It's been great catching up with you. Congratulations to Dr. Dosi for, Ravi Dosi for, publishing probably the first good report in our country. Yeah. And of course, we look forward to Professor Chabra spearheading this whole CCI initiative. Wonderful for all of us.
Thank you so much. Thank you so much. Bye, everybody.
Thank you so much. Bye.
Bye.